this video we're going to be talking about upper extremity sensation testing. Most of the time we're doing dermatome testing initially, but sometimes we will need to do little peripheral nerve paths as well, or peripheral nerve distributions as well. We'll talk about some common differentiating that we need to be able to be working on there. Oftentimes we talk about starting at C4 up here. We could start higher. Radiculopathies are just more rare up there, so often we're not. Typically people are coming in with lower extremity symptom issues. There's a couple ways of doing this. Sometimes we talk about, people just do the quick movement there or slow movement a little bit. Sometimes it's just a touch. I like just a touch because then it's a little bit more simplistic. And then they can feel it. If they don't feel it, I want to do a little movement. Anytime you think you have a change in sensation, you better be able to reproduce it. If he doesn't feel that, and the next time I go out there and I touch it, he can feel that. Okay, the next time I go up and touch it, if he doesn't feel it, he better not feel it anytime. If he's like, oh yeah, that feels normal later, then he just wasn't paying attention good enough early on. It needs to be reproducible. That is essential when we're doing sensation testing. So we first start, we have C4, C5, and I'll go C6, just on the lateral border, 7 middle finger, 8 is lateral border here, T1 is just medial forearm there. If there's deficits anywhere, or any alterations, again, reproduce it, and then go somewhere else just a little bit different there. Common ones that we need to look at is people say they have numbness or tingling in their hands. And sometimes they come in here and they'll draw it out for you. They'll say it's these 3 and it's actually only on the inside of this one. Those people are easy. Those are not the people that we need more training on. Or they may say it's just this one and half of this one. It's to be like, oh, it's just the whole hand. But I'm not feeling it right now. Then you need to say when you go home, or next time you feel it, I want you to rub back and forth on this 4th finger here. And I want you to know if you feel like it's different on either side. And so you want to have them go back and forth that way, because sometimes that helps us with the diagnosis and figure out how best to help you. Sometimes people will just notice a change on one side versus another. And they may not. But if they do, then that's a really good information, because remember, the median nerve is on this half of the finger, and the ulnar nerve is that half for sensation. And peripheral nerve distributions are more specific and more, there's more correlation between one person and another than where the dermatomal patterns are. And so if you get any changes, again, you want to reproduce it, and you want to go in a different spot on there. And median and ulnar are the most common. Radial is going to be the back of the hand. And that's when you just want to look at a picture with them. Say, which of these looks like this for you? I'll pull up a picture of the upper extremity nerve distributions. And I'll pull up a dermatome, and I'll pull up a peripheral nerve, and I'll say, which one is yours? It looks like your symptoms are here. And if they're vague, it's going to be dermatomal. If they're like, hey, that's it, then it's whichever one they're pointing to. If they're not sure, then it's dermatomal. Sometimes they're, if they're looking at, it might be this one on the dermatome, or it might be this one on the peripheral nerve, that means it's dermatomal, or it could be a little bit of both. And so never discount that, but first look dermatomal. If it's a little bit of both, I would say treat up here, because for even peripheral nerve only issues, a lot of times we still treat the spine. So we want to see what value we can get from the spine first. So my assumption is spine until proven otherwise. And even if I'm considering it's 2 things, unless it's really obvious that it's a double crush, which is the common terms.